Today I'm going to be talking about a randomized controlled trial that studied the approach of the wait and see antibiosing approach in treating acute otitis media in kids, specifically in the ER setting. So as a quick outline, I kind of just went over that. Okay, and thank you to the team for helping me put this together, and Dr. Drennis as well. All right, so before we start on the paper, just a bit of a review on acute otitis media. So we all know that when you have like a fussy, febrile child in the peds ER, one of the important things we always have to ask is your kid doing any ear tugging, if they're of age to be doing that? And other than a viral URI, an acute otitis media is probably the second most common complaint or reasons that we see kids in the ER, both at downstate at Kings County. I'm sure we've all seen our handful of these types of kids. So you probably recognize the font to the left. It's WikiEM, our favorite website. So WikiEM, as well as the study that I'm going to be talking about, uses the 2004 American Academy of Pediatrics guidelines for the diagnosis of acute otitis media. Since then, there's been a 2013 guideline that's come out with some updates. But these are kind of the 2004 guidelines, which basically says that you need to have the symptoms have an acute onset, so within 2 days of presentation, and middle ear effusion, which here they're saying can be seen as a bulging TM, it can be seen as some drainage in the area, or here in the 2004 guidelines, inflammation, which could be seen as erythema of the TM. So I think, especially intern year, when I was like, I don't really know how to look in the ear. I don't know what I'm seeing. I think if I saw like erythema of the TM, I was like, they have ear infection. But the recent guidelines in 2013 specifically told us that physicians should not diagnose acute otitis media in children without the component of effusion. So just like a red TM shouldn't push us to diagnose acute otitis media. And I think that's an important distinction, because I think here you see this like fussy crying kid, you're like, the TMs are red. I think we should do this, even the wait and see approach for those kids. But based on the guidelines now, even if you see the erythematous TMs, antibiotics are not indicated at all. So not even like wait and see our kid does, like they should just not be prescribed antibiotics at all. So we also know about acute otitis media is that it's something that has a high rate of spontaneous resolution on its own without any type of antibiotic, and that the focus should instead be on pain control, adequate pain control, and supportive care. So there was another study, a 2005 randomized trial of amoxicillin, and it showed that kids who received the placebo had, even though they had more pain and fever for the first 2 days, which obviously that's what parents really care about, there was no statistical difference in the adverse effects or adverse events between the kids who received amoxicillin versus placebo. Nor there was a significant difference in the recurrence rate. So basically saying that placebo was non-inferior to amoxicillin. AKA, you might as well give a kid Skittles and like other things that would make them feel happier and like their parents more annoyed than amoxicillin. So that's why this study, I think, is important. As we all know, there's nothing that makes a parent happier than a prescription for antibiotics. And when you're in the downstate, PGY alone, intern year, and you have like 20 angry people there all wanting their kid to be seen for a painful ear, it's really tempting to want to just write that prescription. But this study basically is focused on looking at whether the wait and see prescription approach can reduce the amount of antibiotics prescribed in patients who are diagnosed with acute otitis media. There's also the issue of antibiotic resistance, which is kind of the big reason why for us, we really want to try to reduce the amount of prescribing of antibiotics, in this case, penicillin. And there's also side effects to antibiotics that we prescribe. In the case of penicillin, diarrhea is kind of the more common one. So the study looked at two main outcomes. The primary outcome is going to be the reduction in the prescription of antibiotics. And the secondary outcome that they looked at are kind of more like the clinical outcomes for two groups. Patients whose parents were told to wait and see, and patients whose parents were told to pick up the prescription right away. So although there's been other trials looking at this delayed approach in antibiotic treatment of acute otitis media, most of the studies have been in an office setting where there's already an established relationship between the parents and the physician. And this is the first study that looked at this in the ER setting. So the study was done over a 1-year period for children between the ages of 6 months to 12 years of age. And a total of 238 patients were randomly assigned to either the wait and see group or the standard prescription group. There were certain exclusions to patients in this study, such as other types of bacterial infections happening at the same time, like a pneumonia, if patients were toxic appearing, if they had been recently treated with antibiotics, or if they had complications like previous tubes put in or perforated TM, et cetera. The wait and see group was told not to fill the antibiotic prescription unless the kid is not better or is worse 2 days after the visit, and the other group, the standard group, was told to fill it after the visit that day. Both groups were also given instructions and a complimentary bottle of ibuprofen as well as eardrops, and encouraged to use those kind of in the standard way. So the diagnosis of the actual otitis media was at the discretion of the treating physician. However, in this study, they did try to standardize that by posting the 2004 guidelines all throughout their ED. But of course, this was on a physician by physician basis. The way that they determine the outcome for what happened afterwards is a blinded researcher who called the parents at 3 time marks, the 4 to 6 day, which measured the primary outcome of whether or not they picked up the prescription, and then the 11 to 14 and 30 to 40 day, which is more of what were the clinical events that followed and how did the kid do. So again, these are the 2 primary and secondary outcomes that we looked at. All right, so these are our the first set of main results for this study. I highlighted in green the things that were statistically significant, so had a p-value less than 0.05, and in red the things that were found to be not statistically significant in difference. So the main result is in that first line. You can see that the wait and see group, there were significantly less parents that filled out the prescription than in the standard prescription group. What else was statistically significant was the total days of ear pain. So I think that this is like, interesting, because even though it's only 0.4 days difference in the wait and see group versus the standard group, the wait and see group did have, those parents did have to deal with half a day more of a kid who had ear pain. So I think it's interesting because from our standpoint, obviously, this is very significant that wait and see reduces the picking up of the prescription. But from a parent standpoint, maybe it's worth it to them for the antibiotic resistance. So yeah, for the diarrhea as well, that was the third statistically significant result, is that the kids in the standard prescription group, there was significantly more kids who got diarrhea than in the wait and see group. I don't have kids, but I don't know, maybe, exactly, like maybe I'd take the diarrhea over a fussy kid. I don't know. Yeah, I'm not. Yeah, but you can see in the red, so that the red is showing that there's no significant difference in the parents who said that they had ear pain versus fever. So whether or not, you're in the wait and see versus the standard prescribing group, there wasn't really any difference in reporting ear pain and fever. The other part of the results here is basically just showing that, within the parents who filled the prescription, they were more likely to report ear pain and fever within the group that was in the wait and see group as well. So kind of the takeaways from this study, it's the first of this kind in the emergency department, which kind of shows that the wait and see approach can be used even when you don't have this clear established relationship with your primary care. Maybe this kind of approach can be used for other things where we kind of prescribe antibiotics but aren't really sure if a patient needs them. The takeaway is that this approach reduced the use of antibiotics by 56%, and that ear pain and fever isn't actually going to be different in the follow-up. So picture of a kid with candy, because maybe parents should just be nice and give their kids candy and ice cream. And Motrin, yeah. We just have to be done at 11:40. Yeah, yeah.
But she still has another piece.
I don't know.
We started late.
Yeah.
All right. If you noticed, Joy's tables, you know, she had relative risks in there, and that's what we want to do. We want to talk about relative risk or any way to discuss the effect size. So when you have good morning. When you want to make clinical decisions about whether a treatment is effective or whether it is harmful or how effective it is, you need something what we call effect size. And effect size measure the magnitude of benefit or magnitude of harm. And there are ways to discuss or measure the effect size. And these are a bunch of terminologies that you've heard: odds ratio, relative risks, relative risk reduction, absolute risk difference, and number needed to treat or number needed to harm. So we're just going to quickly go over these numbers, and hopefully you'll have a better understanding of what these mean when you read a paper. A risk of an event is the number of events divided by all options. So let's say you throw a dice. The risk of having a 1 is 1 out of 6 because you have 6 options in a dice, and 1 out of 6 is the risk of having a 1. Odds is slightly different. Is the number of the chance of an event happening divided by chance of event not happening. So in the case of the dice, the odds of having a 1 is 1 to 5, right? 1 chance of having a 1 and 5 chance of not having a 1. So that's the difference between risk and odds. So if you throw 2 dice, I just learned that you can use dice and die interchangeably, so it's easier to say dice. If you throw 2 dice, the risk of having a 1 in the top one is 17%, which is 1 out of 6. The risk of having a 1 in the second one is also 1 out of 6. And if you divide the 2 together, the ratio is two risks together. The risk ratio is 1. That means the risk of having a 1 in one dice is the same as same risk as having a 1 in the second dice. Same thing with odds. The odds of the first dice having a 1 is 1 out of 5 or 20%. The odds of having a 1 in the second dice is also 20%. And your odds ratio, or the ratio of these 2 odds, is the same or 1. Now, if the risks are different in the 2 dice, on the top one, let's say that disease will be 1 and 2. So the disease in exposed, the risk of disease in the exposed will be 2 out of 6. And the second one will be 1 out of 6. And therefore you get a relative risk or risk ratio of 2. That means the risk of event is twice in the top dice compared to the bottom dice. Okay. The odds will be also different. It will be 2 out of 6, 2 to 4, which is 50%, versus 1 to 5, which is 20%. And dividing these 2 will give you an odds ratio of 2.5. Again, this means the odds of disease is 2.5 times in the top dice than the bottom dice. So let's imagine, let's put this in clinical terms. Let's imagine we have two groups, 100 patients in the control group, 100 patients in the exposed group, and 10 patients in the exposure group had the outcome, and 12 patients in the control group had the outcome. The odds in the first group will be what? The odds of outcome will be 10 divided by 90, right? Because we're talking about odds, event happening to event not happening. So 10 out of 90, that's 11%. In the control group will be 12 out of 88. And now you have two odds. Odds ratio is dividing these two odds, and you get an odds ratio of 0.79, which means the odds of having the outcome is 0.79% in the exposure group compared to control group. For the risk ratio or relative risk, again, because we are calculating risk, it's the number of events divided by the total N. So in this, the risk in the first group will be 10%, 10 out of 100. And the second group in the control group will be 12 out of 100. And dividing these two together will give you a risk ratio of 0.83%. That means whatever the risk of event is in the control group, in the exposure group, it will be 83%. So relative risk or risk ratio, basically that's how we calculate it. It generally is calculated in prospective studies and represents the ratio or the risk of the disease in the exposed individual divided by unexposed. So just remember the equation. On the top, you have the risk in the study group. At the bottom, the risk in the control group. So that's how relative risk is calculated. Odds ratio is usually for retrospective studies, and when they do logistic regression, that what the software calculates odds and usually is used as a representative of relative risk. Absolute risk difference is probably the most intuitive, the most honest, the easiest way to measure the effect size or to present the effect size. In the first group, you have 25% of patients experience the outcome, or 4 out of 12. In the second one, half of the patient experience the outcome. The absolute risk difference is 25%. It's easy peasy. There's no trick to it. Everybody can understand. This is called absolute risk difference, and that's where you just deduct the risk in each group from each other. Relative risk we just talked about. The relative, just remember the risk in the study group divided by risk in the control group. So if our relative risk is 0.25% or 0.25 or 25%, that means whatever the risk is in the control group, the risk in the study group will be 25% less. So if 10% of patients die in the study group, in the control group, only 2.5% are going to die. If 60% of patients in the control group get hospitalized, in the study group, only 15% of them are going to get hospitalized. That's what the 25% relative risk means. The one is always a reference, which means the risk in both groups is the same. Can relative risk be higher than 1? The relative risk of in one of your thing, the relative risk was 4. So if the relative risk more than 1, is it good or bad? Well, it depends on the outcome. What if it's survival, right? So a relative risk of survival being 2 means the patients in the study group survive twice as often as the patients in the control group, right? So relative risk can be more than 1. That means the event is happening more in the study group. And if that's a good outcome, that's what you want. If it's a bad outcome, you want it to be lower, right? So again, 25% means whatever the risk is in the control group, the study group will experience 25% of that outcome. Not very complicated, right? But you can make it more complicated. So remember we said the one is kind of a reference, and we look at the relative risk from point of view of reference of 1. That means There's no difference between the two groups. Now, they have come up with something called relative risk reduction, which means how far does that treatment drops the relative risk from a relative risk of 1. So relative risk of 1 means the treatment has no effect. The risk in both groups is the same. And then we give them the treatment and we have a relative risk. How far we drop that relative risk from 1 is called the relative risk reduction. It's really not intuitive. Nobody can understand it. Nobody can explain it to the patient. Why do we use it? We'll see. The tricky thing about relative risk is that if the baseline risk, you have to pay attention to the baseline risk, right? On the top row, the difference between the baseline risks is really not much, but relative risk reduction is 60%. In the bottom row, the difference is huge, but the relative risk is still 60%. So in order to interpret relative risk reduction, you need to know the baseline risk. Number needed to treat, it's a very easy concept, and it's something that helps you communicate the effect size with the patient without having to use complicated or statistics. Basically, the concept of number needed to treat is most people think that if you have otitis media and you give antibiotics, the antibiotic is going to take care of the infection, right? That's most lay people think, even physicians. But in reality, when you apply a treatment, there are a group of patients who are going to benefit from the treatment, a group of patients who are going to be harmed by that treatment, and there are a bunch of people in the middle that are neither going to benefit from it nor get harmed by it, right? So just remember that any time we treat something, there are 3 groups: benefit, harm, nothing in the middle. And number needed to treat basically represents the number of patients that are going to benefit from the treatment, and number needed to harm will represent the number of patients who are going to be harmed by the treatment. And it's very easy to calculate it. You just calculate absolute risk difference that we just talked about, and then 1 divided by absolute risk difference will give you number needed to treat. And the way you present it, you say you have to treat 50 patients who want to benefit from the treatment, and the benefit, you have to be specific what you're talking about, whether it's pain relief or survive and not die. The outcome has to be very clear. And number needed to harm, basically the difference, the absolute risk difference between the adverse events, and then 1 divided by absolute risk difference. And you say 33 subjects need to be treated for 1 to be harmed. So it's very easy, and you can use this to communicate with the patient. And you say, it's not like I'm going to give you the antibiotic and your kid is going to get better. In fact, you have to give antibiotic to 50 children for 1 of them to benefit from it, to have this or that. So let's practice what we just talked about in a few examples. This is my favorite paper for this example. This is Tamiflu for preventing pneumonia after influenza. So they had kids who had flu, and they looked to see which percentage of those patients had pneumonia, which percentage of them had Tamiflu, and which person didn't. So the objective is to show that Tamiflu prevents influenza-induced pneumonia. If you read, this is the abstract, it says overall, children who received Tamiflu for the treatment of physician-diagnosed influenza were 52% less likely to be clinically diagnosed with pneumonia. This paper has a lot of issues and other methodological problems, but we're not going into details. However, 52% less likely to be diagnosed with pneumonia is a big deal, right? If you are a pediatrician, a family physician, you work in an urgent care, and you read this paper and it says 52% less chance of pneumonia after flu, you're going to pick up your pen and paper or go to your computer and order Tamiflu for every patient that you diagnose with influenza. This is the table. So they actually give you all the numbers. So you have two patients, Tamiflu group, placebo group, or no Tamiflu group, and you have all the numbers for the outcome. So let's look at just the outcome of pneumonia. The risk in the study group was risk of pneumonia in the study group was 29 out of 4,400, right? That's 0.65%. The risk in the control group was 1.4%, right? The absolute risk difference is 0.75%. So this is a problem because if you are a pharmaceutical company and you're expecting to make billions of dollars, you cannot go to a doctor's office and say, if you give Tamiflu to the children with flu, it's going to reduce the risk of pneumonia by 0.75%, by less than 1%. That's not going to sell, right? So what do you do? And that NNT would be 133. So you have to treat 133 kids with Tamiflu for one of them to not have pneumonia. We calculate relative risk. Remember, relative risk was the risk in the study group divided by control group. This divided by this. Now we have a relative risk of 0.46%. So that means whatever the risk of pneumonia is in the control group, the risk in the study group will be almost half of it. And then relative risk reduction is 1 minus that. And now, bam, you have 54%. And you can go to the doctors and say, this medication reduces the relative risk of pneumonia by 54%. However, you remember, sorry, I'm going to go back. Do you remember here seeing relative risk reduction? Do you think that's an accident that wasn't mentioned? When you read this, this sounds like an absolute risk difference, but they forgot to mention that that number was relative risk reduction. So you know why they use, mostly pharmaceutical companies use relative risk reduction, because it exaggerates the numbers and it gives you a huge effect size, even though the actual difference is pretty much nothing. So that 54% came from, your relative risk was 46%. And the relative reduction was how far the treatment dropped the relative risk from 1. Good luck explaining that to your patient. And then this is a Paxlovid. This is the study of Paxlovid for preventing hospitalization in patients with COVID. By now, you know that this 89% sounds fishy, right? It's too good to be true. And in reality, the risk of death or hospitalization, they should not have combined the two of these, because actually like one patient died in one group and nobody died in the other group, but still they combined the two together. But let's let them have it. The risk of death or hospitalization in the placebo group was 7%. The risk of death or hospitalization in Paxlovid group was 0.8%. The absolute risk difference, which is something that we always have to do, is 6.2%, which brings your NNT to 16. So you have to give Paxlovid to 16 patients with mild COVID to prevent 1 hospitalization. In the face of a pandemic, a 6.2% absolute risk difference is significant. It's not nothing, but this 6.2% is not sexy enough to sell Paxlovid. So what do? You divide this by this. Remember, the relative risk is the risk in the study group, which is 0.8% divided by 7. And that gives you the relative risk of 11%. And relative risk of 11% means whatever the risk is in the placebo group, it will be 11% in the study group. And then when you do relative risk reduction, it brings you down to 89%. Now this sells, right? Now that Dr. Wilson and Deborah something went to the Fox and said, this is a game-changing medication. It reduces death and hospitalization by almost 90%. Everyone should get Paxlovid, right? That's where it comes from. we are running out of time. I'm going to skip this one. So Joy mentioned that when we are in the emergency room and we are running around, we have a lot of patients. We don't have time to look at the statistics. She's right. But again, NNT is a very easy way for you to make clinical decisions. And especially if you don't have time to go, do an extensive literature search and pull systematic reviews or RCTs and analyze them, you can go to nnt.com and quickly, full disclosure, I'm the editor-in-chief for this website, but it's free and I don't get paid. Nobody gets paid. It's a free access resource. You can quickly go to nnt.com and it gives you a one-page summary based on usually a solid systematic reviews such as Cochrane, and you can just look up the NNT. Green, we have a color coding there. You have green, which means the treatment, the benefit is more than harm. We have yellow, which means you still don't know. And red means harms are almost the same as benefits. And then black means harms are more than benefit. But anything you see green, and it will gives you the NNT. So you know that if you give corticosteroids for sore throat, it will give you an NNT of 5 for pain reduction in 24 hours. And then there's a 2 or 3 paragraph underneath that you can quickly read. And then when you go home, you can do your extensive search as you do every night and read your systematic reviews and other things. So check out nnt.com and the 2 considerations. Every time the absolute risk reduction, but you see it when you have one RCT, when you have one study, you can calculate the difference between the rates in control group versus the study group, and that gives you the absolute risk reduction. Meta-analysis is a little bit different because the software adjusts the number for a lot of things. So they have to give you the absolute risk reduction. And they now most of the time, new Cochrane reviews, they give you the NNT and absolute risk reduction, which is calculated by meta-analysis. The other thing is, it's a common mistake that I see. Every time relative risk crosses the 95% confidence interval for relative risk crosses 1. Remember, 1 was when there was no difference between the two groups. Every time relative risk crosses 1, you don't really need p-values like in the table that Joy showed. You really don't need a p-value. If the 95% confidence interval for relative risk crosses 1, that's not significant. When the difference between the two groups is not significant, you're not supposed to calculate NNT or NNH because if there's no benefit, there's no number needed to treat. If there's no harm, there's no number needed to harm. So just be aware that every time you only calculate NNT and NNH when the difference between the two groups is statistically significant. And how do we know that? When the relative 95% relative risk, 95% confidence interval for relative risk doesn't cross 1. Okay, Joy has a few more minutes.
All right, so just the last, thanks, Dr. Z. All right, so just this last quick part is basically a tool that you can use when you're looking at a paper to think about whether it's a paper that you should trust or base your clinical practice on. So I use this RCT checklist from Oxford, I think, Center for Evidence-Based Medicine. Thank you, Esteban, for helping me with this. So one of the questions you want to ask is, was the assignment of patients to the treatment groups randomized? The best way to do that is with a computer, which in this study, it was done with a computer, basically is what that's saying. Allocation concealment is a concept that Dr. Z helped me review, which is basically just that allocating the patients to different groups is done in a way that reduces selection bias. So like in this study, for example, which patients were going to be in which group was assigned with like randomly like discharge papers placed in opaque folders, essentially, and the physician wasn't able to see that. Obviously, once the patients were assigned, the patient and the physician had to know what the discharge paper said, but that order or which patients were in that happens before the randomization, and that's called allocation concealment. And then blinding is a little different because that happens later. So were the groups similar at the start of the trial? Most papers have this where they kind of break down the demographic of the patients in the study. You can see here that in both groups, there was no real significant difference in a bunch of demographic factors, which is important in your study as well. Were the groups treated equally? In this case, yes, they were treated equally, other than obviously the discharge instructions for antibiotic prescriptions. As we talked about the free bottle ibuprofen, PCPs were contacted for both groups, and both groups received calls at the various time marks. And were all patients who entered the trial accounted for? So this is kind of looking at loss to follow-up. In small studies, less than 10% loss to follow-up is considered to be okay. In larger studies, less than 20% is okay. So for this small study, the loss to follow-up and for the primary outcome was less than 10% for both groups. And they almost made it for the secondary outcome groups. And then were the patients and clinicians kept blind? So in this study, actually, no, the patients and clinicians were not blind to which group they were in, but the evaluators or the outcome assessors, as it lists there, were blind, like as in the people making the phone calls. They were blind to which group the patients were in until the end of that time frame. So this is the summary. The paper met most of the standards. That's it. Thanks.